morning. This week is week number 9, and we're going to cover obstructive sleep apnea syndrome. We have 4 objectives to get through this week, and we're going to start here in just a minute. I hope the class is going well for you and you're learning from my lectures. Again, if you have any questions at any time, please feel free to email me and I'll be glad to try to answer them. So let's get started with this week, Unit 9. This week we're going to cover obstructive sleep apnea syndrome, and our objectives include explain the diagnosis criteria for obstructive sleep apnea, explain the epidemiology of OSA including the prevalence and risk factors, explain in detail the steps of diagnosis of OSA, and list and explain the variant on snoring and OSA. The first objective we're going to cover this week includes explain the diagnostic criteria for obstructive sleep apnea. So some of this information I'm giving you today may be a repeat of previous weeks, but kind of to build the foundation so we can understand a little bit more about obstructive sleep apnea and how to diagnose it. So to start off with, obstructive sleep apnea is a sleep disorder characterized by repeated obstruction to the airway during sleep. The airway intermittently narrows or collapses, causing fragmented sleep and contribution to severe health consequences if left untreated. OSA is the most common of sleep-related breathing disorders, marked by abnormal breathing during sleep. Sleep-related hypoxemia is also part of obstructive sleep apnea. Certain physical features can also make a person more likely to develop OSA, and they include a lower jaw that is small or positioned farther back, a tongue that is enlarged at its base, large tonsils, a neck size larger than 17 inches, excessive fat surrounding the throat. Also, we want to look at the BMI. You're more likelihood to developing OSA as your BMI goes up. As far as sex, OSA is highest in men and assigned male at birth, and women or people assigned female at birth is the highest post-menopause. And age. Developing OSA increases as a person gets older until 60 or 70 years old, then it levels out. Just a quick review that OSA affects around 1 billion adults worldwide. Experts believe that actual prevalence may be higher because the majority of cases go undiagnosed. The majority of people with obstructive sleep apnea feel excessively tired during the day and snore loudly at night. Some people with OSA never develop noticeable symptoms. First thing I want to talk about are nighttime symptoms of sleep apnea, and they include loud snoring, tossing and turning during sleep, waking up, feeling the urge to urinate, and breathing through the mouth while sleeping. Oftentimes this is reported by the bed partner, the loud snoring, the tossing and turning, and the breathing through the mouth. Bed partners know what's going on because it keeps them awake, but usually the person having these symptoms does not realize it's going on. So that's why it's important to get all the facts, not only from the patient, but also from the bed partner when doing an evaluation for sleep apnea. Daytime symptoms of sleep apnea include waking up feeling tired, headaches upon waking, dry or sore throat, excessive daytime sleepiness, trouble with memory or impaired intelligence, impotence, or decreased sex drive. Now, these symptoms are usually stated by the patient themselves, not by the bed partner. So if the patient is talking about these symptoms, it's high prevalence that they need to be looked at for a sleep test by the physician. Signs and symptoms that you may have OSA. Again, to reiterate, some of the signs that a patient may be reporting. They feel excessively tired in the day. Someone witnesses snoring or apnea during sleep. They have morning symptoms such as waking up with a headache, dry mouth, or the need to urinate may be signs of underlying OSA. Morning headaches may last for hours and occur most days. Your physician may order a test to detect obstructive sleep apnea, and they include a polysomnography, which is an in-lab testing hooked up to equipment that monitors heart, brain activity, breathing patterns, arm and leg movements, and blood oxygen levels while sleeping. It might be all night or part of a night. Sleep study can also help look at other disorders that can cause excessive sleepiness, but require the different treatments. You may want to get a home sleep study or patient movement recordings. What to expect from your doctor. He or she will ask a lot of questions, and they may include some of these. Have your symptoms been off and on, or do you always have them? Do you snore? If so, does your snoring disrupt anyone else's sleep? Do your snoring in all sleep positions? Do you snore in all sleep positions or just when sleeping on your back? Do you ever snort, gasp, or choke yourself awake? Has anyone seen you stop breathing during sleep? How refreshed do you feel when you wake up? Are you tired during the day? Do you have a headache or dry mouth when you awaken? Do you doze off or have trouble staying awake while sitting quietly or driving? Do you nap during the day? And do you have family members with sleep problems? What can the patient do before the appointment? Be aware of pre-appointment requests, like the sleep diary, record of your sleep patterns. Write down your symptoms, write down personal information, bring a list of all medications, take a bed partner along if possible, write down questions to ask your doctor. For obstructive sleep apnea, some basic questions to ask the doctor. What's the most likely cause of symptoms? What tests do I need to do to go to the sleep clinic? Do I need to go to the sleep clinic? What treatments are available and which do you recommend? Other health questions, how to manage these conditions. For mild symptoms of causing OSA, your doctor might recommend lifestyle changes, and they include lose weight if you're overweight, exercise regularly, drink alcohol moderately, quit smoking, use nasal decongestants or allergy medications, don't sleep on your back, and avoid taking sedative medications such as an anti-anxiety drugs or sleeping pills. Okay, we're going to move to the next objective listed on your syllabus, which is explain the epidemiology of OSA, including prevalence and risk factors. We know that OSA is highly prevalent in adults, especially the mild to moderate, and it has been increasing over the last 25 years. This is partially due to the increasing of obesity in the developed world and can reach large minorities to majorities of specific populations. Example would be older males. The big three risk factors include being a male, sex, higher body mass, and age greater than age of 8. In women, it is not at all a rare condition. We have obesity as a reason. Relation of sex and OSA diminishes with older age, and prevalence in older women becomes closer to men. We also know there's a genetic component of OSA. Condition is approximately 1/3 inheritable, and some inheritability is mediated by excess body mass. There's possible race-related factors such as facial and upper way morphology. Physical inactivity, which is independent of body weight, and excess alcohol use contribute. The quality of life, generally, severe OSA, independent of age, sex, and obesity, is associated with a wide range of quality of life diminishing and life-deprived afflictions. This includes daytime sleepiness, car crashes, depression, cardiovascular disease, cerebral vascular morbidity, cognitive and metabolic dysfunction, accelerated mortality, whereas its estimated association of outcomes with mild to moderate OSA exclude considerable inconsistency. There has been noted a potential role of severe OSA in cancer morbidity. There's a lack of clarity and consistency in regards to the importance of milder contemplated even a decade ago. There's limitation of observational methods used over the last 25 years. The apnea-hypopnea index is lumped together in OSA. Let's talk about some risk factors for OSA in adults. First of all, it's very prevalent in adults. Out of 5 adults have at least mild OSA. 1 in 15 adults have OSA of moderate or worse severity. 75 to 80% of OSA cases can benefit from treatment and they remain undiagnosed. OSA symptoms of disruptive snoring, breathing pauses, and excessive daytime symptoms are reported by bed partners but never acted upon. More risk factors for OSA in adults. Women with OSA are less likely to be evaluated and diagnosed. OSA survival in female OSA patients is suggesting that OSA in women may be diagnosed late in the course of the disease or not aggressively treated. It's related to hypertension, sleepiness, cognitive dysfunction, and older person. Okay, some more risk factors. Morbid obesity, increasing body mass, neck circumference, waist to hip ratio, non-obese persons. Weight loss has shown to be consistently substantial in decreasing OSA. Craniofacial and upper airway structure have a role in obstructive sleep apnea. Skeletal or soft tissue abnormalities, for dysmorphisms related to mandibular and malar size and position, narrow nasal cavities, tonsillar hypertrophy, enlarged tonsils and adenoids during childhood, lower face and jaw, and surgical corrections of these anatomic defects can reduce AHI. Increased risk of OSA in families of patients with OSA. This is related to a shared lifestyle and supports a genetic predisposition. OSA is reported in more severe to be more severe in Asian patients, higher prevalence of OSA in younger Black men and older Black persons, and smoker possible risk factor due to the airway inflammation, and smoking-related decreased in the blood nicotine levels at sleep. This effect may be reversible if they quit smoking. Hormonal differences account for sex differences and can be an indication for possible OSA. Sex hormones changes in menarche, pregnancy and menopause, and postmenopausal. Weak effect of hormone therapy in reducing apnea and hypopnea has been discovered. And nasal congestion at night, whether it's due to allergic rhinitis or during acute upper respiratory tract infection, has shown an increase in AHI in both experimental and epidemiological studies. No study indicated to address the effects of pharmacology treatment of nasal congestion at this time. Comorbid conditions are associated with OSA in diabetes, hypertension, coronary artery disease, myocardial infarction, congestive heart failure, and stroke. The association to other comorbidities may be due in part to risk factors common to all of these conditions. It may also reflect a role of OSA in the etiology of these conditions. Correlations of OSA are included in excess body weight and hypertension. There's an overlap with diabetes and insulin metabolic syndrome. Patient with diabetes should be questioned about OSA. There's a prevalence is high with patients with hypertension. Congestive heart failure with those who have OSA show a decrease in ejection fraction and decreasing systolic blood pressure and heart rate. And it's highly prevalent in patients with stroke and transient ischemia attacks. Treatment of functional outcomes and rehabilitation is potential in these patients. Patient awareness of sleep-related problems depends upon the adequacy of comments from bed partners, so it is difficult to quantify excessive sleepiness by the patient. Pay attention to the classic symptoms of disruptive snoring, breathing pauses, and daytime sleepiness, which is critical but subjective nature of these conditions. It is important to rule out or treat alternative causes, including poor sleep hygiene, depression, hypothyroidism, drug abuse, and chronic pain syndrome. Treatment of disruptive snoring or even witness apnea without excessive daytime sleepiness is controversial of OSA patients. Currently, OSA is underdiagnosed. Possibility of reporting loud, disruptive snoring, witness apnea episodes, or excessive daytime sleepiness. Consider a more in-depth history and clinical assessment of updated risk factor described. Decide whether there's a strong possibility of OSA for the need evaluation with PSG, and consider alternate diagnosis. Be suspicious of comorbidities. Okay, we're going to move to objective number 3, which is explain in detail the steps of diagnosis of OSA. Your doctor will evaluate your condition based upon your signs and symptoms. He will examine and do tests such as the Stop Bang, Sleep Questionnaire, and Malapati score. The physician will examine the back of the throat, mouth, and nose for extra tissues or abnormalities. Measure the neck and waist circumference and check your blood. May refer you to a sleep specialist and conduct an additional evaluation to diagnose your condition, to determine the severity of your condition and plan the treatment. Evaluation might involve staying at a sleep center overnight to monitor breathing or other body functions. The last objective of this week is to list and explain the variants of snoring and OSA. Nearly everyone snores at least occasionally, and habitual snoring is common. 44% of people snore on a regular basis. But snoring that is loud, frequent, and accompanied by gasping, choking, or pauses in breathing may be a sign of sleep apnea. Typical snoring, breathing continues uninterrupted. With sleep apnea, breathing is repeatedly disrupted, causing multiple or partial awakenings. About 44% of men and 28% of women ages 30 to 60 snore on a regular basis. Snoring occurs when the air can't move freely through the passageway at the back of the nose and mouth, usually due to a loose, floppy tissue in the tongue or throat. In general, snoring itself does not appear to be harmful to your health, but loud snoring can disrupt a partner's sleep. High volume snoring with brief pauses in breathing is a hallmark of obstructive sleep apnea. Generally, snoring itself does not seem to be harmful to your health. Loud snoring can interrupt a partner's sleep, potentially triggering relationship problems. High volume snoring punctuated by brief pauses in breathing is the hallmark of sleep apnea, causing the person to stop breathing for at least 10 seconds, sometimes hundreds of times at night. 25% of men and 10% of women have linked to several health problems, but especially heart and blood vessel disease. Physical traits and lifestyle habits that contribute to both snoring and sleep apnea. What factors are known to cause snoring? They may include obesity, use of alcohol or sedative drugs, smoking cigarettes, sleeping on your back, nasal congestion, nasal polyps, which are small growths in the nose, a bend in the wall between the nostrils, an underactive thyroid, swelling in the tonsils or other tissues near the throat. So when do you talk to your doctor about snoring? Loud snoring on a regular basis, breathing difficulties when you sleep, waking up unrefreshed even after sleeping at least 7 hours, regular morning headaches, problems with concentration or memory, and difficulties staying awake at work or school or during the other times during the day. Okay, that concludes this week's 4 objectives. Rather short lecture this week. Kind of reviews some of the stuff we covered in the past and sets the stage for our next week's lecture on central sleep apnea and hypoventilation syndromes. So if you have any questions, again, feel free to contact me. It's been a busy week, and I hope that you're still interested in sleep apnea and learning from my lectures. I hope to join you for a live Zoom tomorrow night, maybe. Well, it'll be tomorrow morning for you, I believe. So have a good week and take care.